It's great to have a chance to follow up from our annual meeting. The field is moving fast. There's some other exciting new developments to touch base in terms of combination therapy and some new data in regards to getting LDLs down to low levels. It's nice to be joined by my colleagues.
Hi, I'm Erin Michos from Johns Hopkins, and I'm glad to be back with my colleagues to continue our discussion about lower LDL for longer is better.
And I'm Joe Saseen from the University of Colorado and immediate past president of NLA. I'm really happy to know that lipid evidence continues to evolve and it gives us things to talk about.
So some nice data presented at the AHA. You know, we talked about, we have some newer therapies in terms of the field of non-statins. We've had the monoclonals. We have an siRNA in glycerin. And always when there's a new agent like that, it's important to take a look at the new data. Erin, you want to give us an update on a couple of things that have come out since we had a chance at our annual meeting to discuss this?
Yeah, so if you remember the Orion series, Orion 9, 10, and 11 were our phase 3 trials evaluating inclisiran for LDL lowering in patients with ASCVD or high risk with FH. What was shown at AHA by Dr. Ray is that now with 4 years of follow-up, there continues to be excellent safety profile with no signal for increased adverse events and continued sustained LDL lowering in the range of 44%. Now, none of these were dedicated cardiovascular outcome trials. We're waiting for that with the Orion 4 trial, but also recently published in November 2022 in the European Heart Journal by Dr. Ray. They published the pooled patient level analysis from Orion 9, 10, and 11, looking at cardiovascular events. And we see this signal that those patients that were randomized to inclisiran experienced a 26% lower risk of major adverse cardiovascular events over the 18 months of follow-up of these trials. And so this is really encouraging, and while we await for the actual dedicated cardiovascular outcome trial to be completed.
So I think it's some exciting data. You know, the issue of combination therapy, we talk about in terms of treatments, we usually talk about efficacy studies. And we mentioned these are typically our randomized trials, and we'll look at the comparison for LDL reduction or events. But there's also been, I think, an approach towards getting more data in terms of effectiveness of approaches. You know, there was a trial in Korea where they compared a lower intensity statin adding ezetimibe to high intensity statin, and a pragmatic study that was done, published in Lancet. And they found that the approach of a combination was non-inferior for events, numerically a little bit better for reductions, but also got lower LDLs with better adherence. So I think these are the types of things that are important as and there's a lot more coming up in terms of this concept, because inclisiran, you know, and Joe, this is an issue we take a look at from both the clinician, and then if we look at the pharmacy and the PharmD, the issue of adherence and clinical effectiveness. Now, there's some things that are in the pipeline, taking a different approach, looking at this issue, for example, because one of the thoughts is if you were to have an every 6-month administration, maybe combined with a prevention visit, that might actually improve adherence. Any comments from both of you? We're in this interesting area of science. We're in implementation where you kind of have first of all, what's the efficacy? And then the next thing is, which we haven't done enough of, is which approach is the most effective approach?
Yeah, from what I've seen, as far as the most effective approach to improve adherence, I don't think we have one single strategy. What we do know is we have a ton of evidence showing that non-adherence is a problem with oral therapies. We don't have as much evidence with injectable therapies, whether it be the PCSK9 monoclonal antibodies or inclisiran. You would assume, based on the model that we have with inclisiran, where you have to go to an injection center, whether it be a clinic or an outpatient facility, to administer the drug, that would improve adherence. It makes sense, and I think we have some preliminary information based on not real world, but efficacy studies showing that that is true. With the PCSK9 monoclonal antibodies, adherence is going to be higher just based on the model of how people get those drugs. They're typically through specialty pharmacies, though transitioning more to regular pharmacies. And because of the cost of those drugs, there's really an incentive for proactive approaches, such as the pharmacy calling the patient when they're due for a refill, which is not commonplace with oral therapies. So I think we're learning about the best approach to improve adherence, but it's probably multifaceted, where you need a team-based effort. It can't just be the physician. It has to also be efforts through the pharmacy. And, money may push this also, because some of our value-based contracts, which reimburse our healthcare systems, they're looking at adherence to statin therapy and forcing health systems to do prospective outreach, whether it be through smart apps, through alerts to patients, through the electronic health record, to actually increase those statin adherence rates as a marker of quality to increase value and increase reimbursement.
So one thing I would like to bring up again is, which hopefully we will get changed with all the data we have now about non-statin therapies, added to statin therapies. We're going to have to go beyond a quality metric to be, was a statin prescribed and was there adherence? We've got to go back to measuring LDL cholesterol. Just as, we look at blood pressure, it's the blood pressure level. Diabetes is the A1C. You don't get credit for just having written a medication. You only get credit for achieving the blood pressure reduction. So I do think that this is going to be an issue that the field's got to get back on track in regards to this, because one of the few things that's been shown to actually improve adherence is the measurement of LDL cholesterol. People know they're getting results with it. Now, there was another really provocative study, and we talk about adherence, and sometimes there's a discussion with patients of, okay, let's just maybe try a little bit of statin. And people will come in, they're taking lots of supplements. There's a lot of supplements that, people think, and they'll come with a long list of things. I know, Erin, you were an author on this study.
Yes.
Inform our audience of the results of that study.
Right. So a lot of patients, want to do something natural for managing their cholesterol and elevated risk. Of course, there's nothing more natural than a healthy lifestyle and a heart healthy diet. But often they turn to supplements in lieu of, proven efficacious medicines like statins. And the supplement industry, is unregulated. It's a $300 billion industry worldwide, and patients spend a lot of money on these things, and they think they're getting benefit. So we did a trial led by Luke Laughlin and Steve Nissen, Cleveland Clinic, where we enrolled patients at elevated cardiovascular risk, primary prevention patients based on their pooled cohort equation. And we randomized them to either a low dose statin, rosuvastatin 5 milligrams, placebo, or 6 commonly used supplements that people are taking that all are advertised on the bottle as supposedly being good for cholesterol. And these include things like turmeric and garlic and red yeast rice and fish oil. And what we showed is that the rosuvastatin compared to placebo at 1 month lowered LDL by 35%. This is only 5 milligrams of rosuvastatin, and quite a lot of patients had more than 40% lowering of LDL with just a low dose of rosuvastatin. So it may not be surprising that a rosuvastatin lowered LDL more than placebo, but it also lowered LDL more than all of the 6 supplements. But more importantly, none of the 6 supplements lowered LDL any more than placebo, even red yeast rice. And some of them, like the garlic, actually raised LDL. So really those supplements, it was, a coin toss whether the LDL would go up or go down, where every single patient randomized to the rosuvastatin experienced an LDL reduction. And so this is just proof of concept that, these supplements don't work, and patients should take, the proven efficacious medicines that, we know work for LDL lowering.
Yeah, I think there's a misperception. Red yeast rice in the United States, that's not allowed to include the fungal metabolite that basically is a statin. In other countries, like in Canada, they still have some of the red yeast rice preparations like that. And that was because there's potentially drug interactions with this. So it's really something where nothing was effective, and even so if you can just get people even on a extremely lower dose, because even 2.5 milligrams of rosuvastatin is still going to be way more effective than any supplement. 2.5 milligrams 3 times a week is more effective. So this push towards, and I know frequently I've been successful just getting people on even a very low dose, and you add something else to it, and you can get some decent reductions. Now, one other, I think, important thing is that we've had the trials with evolocumab and alirocumab, which were moderate duration. They were, I think, 2.2 and 2.8 median years. And also the long-term follow-up of evolocumab. I thought that was some important information that came out.
Yeah, so in October 2022 Circulation, they published the four-year OLE, or the open label extension data. So these were after the conclusion of the trial, patients that were originally assigned to placebo were offered evolocumab, and the people originally taking evolocumab continued. So we had essentially 5 years more of extension and the open label added to the 3 years in the trial, so 8 total years. And what was interesting is that the patients originally assigned to the evolocumab still had a 15% greater reduction in major adverse cardiovascular events compared to those originally assigned to placebo, but then switched over to evolocumab, meaning that there was continued sustained benefit from earlier initiation of intensive LDL lowering. So lower LDL for longer derived even more benefit, even compared to the people who got intensive LDL lowering a little bit later. And there was still good continued safety signals. So we really need to implement this, these important therapies as soon as possible. And getting back to what you were saying before about LDL as a quality measure, we talked about at our Boston program about the 2022 ACC expert consensus decision pathway, which has reinforced now these LDL goals, that in patients with ASCVD at very high risk, not only do you want to lower the LDL by 50%, but also to achieve an LDL target less than 55. They had that same target of less than 55 for patients with clinical ASCVD who have, LDLs above 190 and FH. And for patients with ASCVD, not at very high risk, an LDL target of at least less than 70. And of course, I think lower is better, and that you really can't go too low. And we should make sure we start this therapy as soon as possible.
Yeah, so that was, I think, pretty striking, is that in the first year of the open label extension, the curves were still going apart. It was a 20% relative risk reduction, even though the placebo group initially was now at 30 again, just like the other group. And then it then became back to 15%, but it stayed 15%. In other words, you never really caught up completely. So you lose by not starting people, you that 15% additional event reduction, despite getting the other group down to 30. And I'm certain that if you looked at the way those curves were going apart, if they'd stayed where they were, we would have seen further relative risk and absolute risk reduction, just as we saw in the statin trials when you had the placebos going for 5 years with it.
And the extension trial, they demonstrated reduction in cardiovascular death too. So,
mortality,
mortality. So if you keep going longer, not only reduction in MACE, but then you start hitting those even stronger endpoints like reduction in cardiovascular mortality.
There was some new data in regards to some of the new agents in the pipeline that might be for combinations. There was some data presented that looks promising for an siRNA for ANGPTL3 and some ApoC3s. Those are going to be down the road. And of course, we've got a lot of things that are moving along. The LPA reduction was for open. We have the two of them. We have both the ASO and the siRNA, but they're both extremely effective, 80, 95% reductions with the siRNA. So very exciting in terms of the things that we could add on in the future, but we have things to add on now. And maybe we'll just kind of close up here. There was a very interesting press release that came out just recently. Joe, did you
Yeah.
want to just bring
The
that
clear,
up?
the clear outcomes, I think we're in the world. If you look at the ACC expert consensus decision pathway, yes, lower is recommended. But look at the non-statin agents that are recommended after statin. There's the ones that have cardiovascular outcome data available, like ezetimibe and the PCSK9 monoclonal antibodies. Well, even though we only have top-line results, so we don't know how much bang for your buck you're going to get, we probably could put 2 and 2 together. Bempedoic acid in the CLEAR Outcome study, which was their prospective cardiovascular outcome trial that looked at patients who were statin intolerant. And if you look at the definition of statin intolerance, that includes partial intolerance. I think about a quarter of the patients had partial intolerance, meaning they're on a little bit of a statin. That bempedoic acid reduced their primary outcome. We don't know how much. It's positive. We'll wait to see actually the real data so that we can analyze it further. But we see the power of outcomes data impacting our standards of care, as highlighted by the ACC expert consensus decision pathway. So it is great that we have another non-statin that reduces cardiovascular outcomes in combination with a statin, or alone is what or without a statin is what the CLEAR Outcomes does also support. But I think we really need to look at the data and cut it apart to see if there is, more of an incremental benefit in different subgroups. So we'll wait to see that, but it's positive, and that's an important finding because it adds yet another tool to our armamentarium of drugs to further reduce LDL and cardiovascular events. And I couldn't agree with you more about adherence. I'm really frustrated when insurers incentivize plans and look at adherence and defines it by fill rates or prescribing rates. That it can be misleading in so many different ways, because sometimes patients don't pick up their medicine. Sometimes they get their medicines filled through discount pharmacies that don't hit that refill record. But the ultimate biomarker of adherence is what you said, which is LDL lowering. So I just wanted to further reinforce that.
Yeah, and even now they'll send the medicine to the person's house without asking. Once you check a box, and so how can you possibly know what someone took or not for it? Well, yeah, I think we're looking forward to CLEAR Outcomes. One thing that was nice in terms of this study, and maybe there's also, the statin intolerance, and particularly maybe tolerating high doses of statins. We see this is more common in women. And this study was one of the first outcome studies. Half the patients were women, right? So it'll be interesting to get more data there, won't it?
Yes, I'm so excited because, historically women are under-enrolled in cardiovascular clinical trials and lipid trials. And so the fact that they nearly had half women participants was really a step up and exciting. And I think it's because they enrolled statin intolerant patients. And when you do trials that are relevant to women and you're able to enroll more women into these trials. And so I think I'm excited that it was a positive result. I'm looking forward to see how positive and to do a more granular deep dive. But good news for our patients, bad news for LDL, but we got more therapies than ever before. So we've really moved beyond, the years where statins were the only thing that we had, and really now show consistency across multiple drug classes that we can lower LDL will translate to meaningful reductions in cardiovascular outcomes.
Okay, well, anyway, it was great to have a chance to give a little bit more of an update. As you can see, the field's moving rapidly, more and more data that it's important to drive LDLs down to low levels, especially in your high-risk patients. Thank you.